So, I appreciate the warm welcome. I really am thrilled for the opportunity to spend this time with all of you, especially amongst fellow medical educators and people that are hopefully passionate and as inspired as I am to make a real difference in our medical education community and certainly for the lives of our patients. And this topic of shame in medicine, I think, is a very tangible and I would argue very important way that we can advance that work. So I'm just real excited to get the chance to share some of my research with you. Rena, can you give me a thumbs up if you're seeing this as a full screen? Okay, great. Um, so I I'm going to tell you how I got started in this work, and I'm gonna start with a personal story. And what I'm going to do first, before I even dive into that, is I'm just going to define shame as we conceptualize it in the work we do. And this comes from psychology. It's really the leading definition of shame, sort of amalgamated, where it's an emotion that occurs when we engage in a self-evaluation, typically in response to a triggering event, and we deem ourselves to be somehow flawed or globally deficient or unworthy in some way. So it's a global negative evaluation of the self. And I'm going to distinguish this further in a minute from guilt. But the goal of this talk is ultimately to put this emotion on your radar. I won't have to spend much time doing that because as fellow humans, you've almost undoubtedly experienced this and will relate to these dimensions of the emotion in some way. But beyond just putting it on your radar, I really want to hopefully spark a conversation in your institution, provide some basic vocabulary for how you might interact with and engage with this emotion, and a greater awareness of its existence, and finally a few basic strategies for engaging with it. This is a woefully inadequate amount of time to gain even a modicum of the depth of what shame in medicine is and can be and means. But I really hope for it to be an initial overview that will spark further interest. If I'm going to carry a metaphor through this talk of fire, and and it's one that helped us as we grapple with some of the nature of shame in our research. And if we consider the shame reaction to be a fire, then I would argue, and my co-authors would argue, that practicing and learning medicine is kind of like existing amongst a pile of matches, maybe that's been coated in lighter fluid. We live and work in environments and in situations and among high stakes that really predispose the experience of shame, that make us at risk of experiencing shame and other distressing emotions. And when I was a second year resident, one of the matches struck and it catalyzed the emotional experience that ultimately led to this entire body of work. And what happened in this situation is that I was a early second year family medicine resident. And if you've heard the podcast that we've done with the Nocturnist, this story is featured at the very beginning. So forgive me for being duplicative with it, but it is such an important story to tell you that I'm gonna convey it. It's also important that if I ask for you to start a conversation about this emotion, that I'd be willing to also share my own experiences with it. And I was early in my second year in family medicine residency on the labor and delivery unit, and I was, early in my training, but yet in sort of a semi-senior role with more responsibility, yet inadequate skill, which is sort of a common experience in medical training, and in an environment that was pretty intimidating and not very warm and friendly. And so, after a 24-hour shift, I was getting ready to leave, and a patient came in having a placental abruption. And in the midst of a lot of commotion, I was pulled into the room to get experience in managing the situation. And so it was me and the obstetrician and a ton of other people, pediatrics team, nurses, uh, MAs. Just it was an obstetrical emergency. The baby was in distress, and it needed to be delivered immediately, and its head was beginning to crown, and the decision was made to expeditiously deliver it with a vacuum assist device because that was really the safest opportunity or option at the time. And so before I knew it, I mean, it's somewhat of just a daze almost. I found myself standing at the foot of the bed, hand on the vacuum attached to the baby's head, delivering the baby. And in the midst of doing the delivery, I did successfully deliver the baby. thank God, because if anything had gone wrong there, I can't imagine how much just worse this would have been. But in the process of doing so, I caused a really severe maternal injury, a very severe vaginal laceration. And this was well beyond what anyone might consider to be an expected outcome of an operative delivery in obstetrics. This was something really much worse than that, um, and it felt like that at the time. I mean, I was just sitting there at the foot of the bed, having seeing sort of the
I'm
product of
on
my
this now.
hand in front of me, um, and and just immediately knew that I had done something way wrong. And I honestly, I think everyone around the bed knew as well. It kind of got real quiet, in my recollection, and this prompted a really significant emotional reaction. The immediacy of the emotional reaction was fight or flight, sympathetic activation, fear, anxiety. One of our participants described it in one of our studies is like your bowels falling out on the floor, just kind of that sinking gut punch of a feeling. Um, Feeling very exposed and like I was being judged very harshly, by those around me through my perception of them. And having this very intense, overwhelming desire to disappear. I mean, it was like a primitive feeling. It was not a cognitively processed feeling. It was like you need to get out of here immediately. And I can't even fully explain why I had that urge. And so I did that actually, and this was definitely not my norm. I mean, um, I handed the vacuum and the baby off to the obstetrician who took over the perineum, and I just slipped out of the room. And when I got out in the hall, I mean, I was in just a state of disorientation and confusion, and I didn't know which way was up. And in this emotional haze, the only thing that was really driving next steps was to just get as far away from that room as I could. Um, and that took me, in a winding manner, literally winding around the hospital, just trying to find a place ultimately to hide. I mean, I needed somewhere that people couldn't find me so that I could process what was going on, what was happening, and to do it in some degree of privacy. And so I found myself on the other end of the hospital, on the other side of a meditation room, in the corner behind a chair on the floor. And I stayed there for a couple hours. Um, and as some of that really intense emotion and the fight or flight died down, then the second phase of this experience developed. And it was the much more jarring, actually, and the one that I was completely unprepared for. Whereas, the spark had been the error, and the initial fire had been the fight or flight and the physical feelings. This was now like a forest fire, and this was a brush fire that was really starting to engulf me. And the nature of that fire was really wrapped up in my self-evaluation. So I now had the opportunity to say, oh my God, like, what does this mean for you? As a resident, as a physician, as a person who just hurt somebody, who is not worthy of being trusted and never should have been. Maybe problematically for me, I'd never really screwed up that bad, and I was kind of a golden child. And so I had gotten used to not screwing up. And this was like, to me, an epic failure. And it was almost like it erased all of that previous achievement or success or competence. And in that moment, it was like the real me had sort of turned up. I felt like broken. I felt like a person that hurts people, a bad doctor, unworthy, incompetent. I mean, you name it. It was going through my mind. And it wasn't like just a casual contemplation. This was like a voice that was screaming at me, yelling at me, and attacking me from within my own head. And that was really upsetting and jarring. And not only did it just feel like crap, but it was very I didn't know what was happening. And I felt completely detached from myself. Over the days and weeks that followed, I eventually um, came to terms with this experience. I didn't know what it was until I found I was also getting out of a kind of a crappy relationship, and just did some soul searching and found Brene Brown, like so many people who were soul searching find. And she had done this great, the great TED talk on vulnerability and shame. And I remember watching it, and I was like floored. Like I could not believe that someone was talking about what I was going through, with such clarity and approachability and accessibility. And I watched that TED Talk like 3 times, and by the end of it, I had taken notes and drawn diagrams, and I was figuring out my own emotional, experiences, and in a really transformative way. And that plus the opportunity to share this with a trusted friend who helped me understand that maybe it was actually just a bad outcome or an unfortunate outcome in the midst of a challenging situation, ultimately helped me recover from what we have called in our research a sentinel emotional event. So, like a sentinel event in healthcare, this is an event that has a lot of morbidity, emotional morbidity, in the life of a practicing clinician or a trainee. And this was certainly a sentinel event for me. And the recovery from that event took weeks, and it took discovering the name of what I was experiencing, self-forgiveness, reaching out, having my perspective shifted, a whole host of steps that now looking back, I can really understand with a lot more clarity. But at the time, it was just sort of a natural urge to try and recover and learn about myself and not, feel that way in the future. Along the way, I really started to look with a kind of a newfound clarity at the world around me, and saw shame kind of everywhere, and the response to errors, and our struggles in learning and learner mistreatment, in some of our interpersonal interactions, and the ways that people were teaching, or how they were feeling as they were being taught. And so I was just curious at the time, and also maybe viewing a career in academics, but certainly not looking for anything to research at this time. I just went into the psychology literature and found a really a wealth of information about shame, and the emotions with which it's associated, like guilt and pride and embarrassment, so-called self-conscious emotions. And then I found a lot about the things with which it's associated: burnout, depression, PTSD, suicidality, impaired empathy, all things that we were struggling with, and increasingly recognizing we were struggling with in medical education. And in that medical education literature, I found, increasing attention to how emotions impact learning, and the role they play. And then that myriad ways of the ways in which medical trainees and wellness can be impaired, many of which had associations in psychology with shame. But despite there being a lot of crosstalk, there was a lot of signal in the med ed literature about that would suggest maybe the presence of shame. There was next to no explicit attention played to it. So a handful of perspectives, a couple studies that were very loosely attached. But ultimately, what I had sort of stumbled right into was this massive gap in the literature. And I couldn't believe it at the time. And I still can't believe it, knowing what I'm learning about shame, is that what is the experience of shame in medical learners, and that being the gap we stumbled into. And so to try and bring this construct of shame in medical education out of the shadows and into the light, we then, after a lot of time spent thinking about this topic and researching it, we set about trying to study it. And we started with a fundamental question. And it's a question that carried across my entire PhD program and the studies we've completed to date, which is a fundamental and foundational one. Without presupposing that medical learners experience shame in the same ways that have been described in psychology, without any hypotheses to test, without expecting to find a certain nature of an experience, we started at a very fundamental level, asking how. And within the how is, what is the nature of shame in medical learners? And how does it experienced relative to contextual factors that surround medical learners? And we ultimately asked this across the continuum of medical education. So we started trying to examine how shame is experienced in medical residents. And then we took a step backwards in time to medical students, and then ultimately a step further, having seen a lot of sort of upstream factors into pre-medical students. So these were all cross-sectional qualitative research studies, but they did seek to understand the arc across the continuum of medical training in medical learners. We use the methodology, really powerful methodology called hermeneutic phenomenology. It's taken from a kind of constructivist, interpretivist oriented paradigm. The goal of it is to provide a rich description of the nature of shame, and its deeper meanings or essences, what gives it shape and what makes it a meaningful and important emotion in the experiences of us as individuals and our environments. The only thing I'm going to tell you about this methodology, except that it's a very practical and powerful methodology, is that among the things that ask the researcher to do is consider the parts or the structures or elements of a phenomenon and their relationship with the whole of the phenomenon. So it's not just about characterizing the various structures of shame, but going further and deeper and bigger to say, well, what is the meaning of those structures? What are the essences, the deeper sort of fundamental truths that we can identify or propose about the nature of shame? And this interplay between parts and whole was very important for the research, and I'm going to utilize it and tell you about some of our data. Before I do that, I'm going to tell you briefly about the theoretical foundation we used. So Tracy and Robbins' theory was kind of at the heart of our theoretical framework. It's a very powerful theory from psychology. And the reason I'm telling you about it now mostly is because I want to use it to help define shame and differentiate it from guilt. Because there is real practical significance of this differentiation and the knowledge of it that you can use as educators, as peers, as caregivers, and also just as people in your lives in the everyday world. So according to this theory, which is one of the leading theories in psychology for the self-conscious emotions, and it has a significant amount of empiric support, is that something happens, there's a triggering event. So you make a medical error, for example. And as a result of that event, the focus of the individual is directed inward. And so the self-conscious emotions, by definition, occur as a part of a self-evaluation. And this is what distinguishes them from the basic emotions like happiness and fear and sadness and elation, which may include a self-evaluation, but they don't require one. To feel shame or guilt or pride or embarrassment, you have to be reflecting on and thinking about who you are. And that's a really important point that I'll make throughout this talk. As a part of that inward look, that self-evaluation, these researchers suggest that we activate two sets of self-representations. The first set of self-representations relate to how I see myself right now in light of this triggering event. So my self-representations were pretty harsh. I was viewing myself in a really kind of nasty way. And the second set of self-representations are what are called our future self-representations, our ideal self-representations. So who is it that we're striving to become? How would the person, our ideal self, the person that we wish we could be, how would that person have acted in this moment, in light of this triggering event? And so salient in a self-evaluation is not only how we feel right now about ourselves, but who it is we're trying to become, the expectations we have for ourselves, the standards we've set for ourselves, and from where those standards and expectations originate. And so there's a third step in which and this is mostly happening subconsciously, although it is very interesting to make it conscious if you can, to pay attention to how you're self-assessing. But mostly subconsciously, we determine, are these sets of self-representations congruent with one another? Have we done something that causes us to see ourselves or feel about ourselves in a way that is closer to who it is we're trying to become? So we've taken steps closer to that ideal self. And if that's the case, then we feel the emotion of pride. Okay, so pride generally is a positively valenced emotion that comes from identifying and seeing ourselves as closer to our ideal. When we have done something that causes us to view ourselves or feel about ourselves further away from who it is we want to be or striving to become, then we feel either shame or guilt. And this is so important and powerful because these two emotions are both negatively valenced emotions. They both do not feel good. This distance between how I see myself and who I want to be is a negative experience generally. It's one that we would generally prefer to not have to incur. But there's a final and fourth attribution that really is what distinguishes these two and that gives this distinction its power. And that is, on what do we place blame for this incongruence? What do we blame for the occurrence of this triggering event that led to this incongruence? Is it something specific, something unstable about us, meaning something that's modifiable, that isn't fixed or static, that's situational or circumstantial? For example, in my case, that would have been the fact that it was only my second ever vacuum assist delivery. So I was new at this procedure. The baby was dying actively. I couldn't see anything because there was so much blood. Everyone was yelling. I'd been up for 24 hours. I probably wasn't prepared to do this and should have spoken up and said, I need more help, or I'm too tired, right? All of those attributions to the ultimate event of the patient um, harm are very plausible and valid, and they're all specific and modifiable, something that I could theoretically do something about or change. When that is the prevailing nature of our attribution, then the prevailing emotion is guilt. When we feel shame, we make an attribution to something global and stable, much more difficult to modify in a moment, non-circumstantial or situational about ourselves. So our intellect, our capability, our competence, our looks, um, our how lazy or not we are, how oriented to detail or not we are, things that are much more difficult to change in a moment, that really orient much more to our global selves. And so Brene Brown describes this best and most simply as guilt, as I did a bad thing. And I feel terrible about that. But this thing I did was bad. Whereas shame is, I'm bad. And the therefore that follows is, therefore I'm the problem. Whereas guilt is, therefore this thing I did is the problem. And what comes next is what got me so excited when I discovered this theory 10 years ago. Because what comes next really matters in a theoretical sense to what we do in healthcare. And that is when we identify something specific that is theoretically modifiable, our natural tendency, the vast majority of us, especially in this profession, is to try and take steps back to our ideal self, to bring ourselves back in alignment with who it is we want to be, especially when it comes to patients. And so when there's something that we can fix, we go about trying to fix it. So guilt tends to inspire a more reparative, proactive, engaged response that is ultimately meant to sort of facilitate healing and repair. And in so doing, theoretically at least, it situates as more of a pro-learning, pro-engagement emotion. It still may feel bad, but the action tendencies and the motivational stance that it tends to inspire is often more constructive. When we feel shame, we kind of want to do the opposite. When we view ourselves in a globally negative light, I mean, it's painful to see yourself the way you feel about yourself when you feel shame, especially if it's really profound, prolonged, chronic, inappropriate, that so-called pathologized shame. It's hard to see yourself in that way through other people's eyes. It's hard to continue risking reinforcing that feeling through either continued transgression or error or mistakes. It puts us in a very self-protective stance that most often inspires attempts to hide, to disengage, to isolate, to withdraw, and often in a wounded stance. And so, in theory, at least, shame is a more anti-learning, anti-engagement emotion, especially when it's pathologized. Now, there's two caveats to this. One is that in any given, well, there's a bunch of caveats, but the two I'm going to tell you, in any given emotional response, it's never either or, right? It's never cut and dry. This is all shame. This is all guilt. It's probably a mixture of some of the two with a whole lot of other emotional junk. and it's much more complex than this theory would suggest. But to the extent that one predominates over the other through the nature of the attributions, there are clear action tendencies that often follow. The second caveat is that I certainly don't want to say that shame is a bad emotion and that it can't lead to learning. It absolutely can, and we have plenty of stories where it did. But that shame generally is a more destructive emotion when it is pathologized, when it's not moved onto something more constructive and oriented to something that we can fix and change. I also will say that shame is evolved emotion. It's super important. We need it. We need it in a functioning society, in a functioning community. It's one of the most powerful signals for when we have erred against a norm or a standard, and it motivates us to reorient back to that group. But it can become very easily pathologized and weaponized. By the same token, I'm not suggesting you should walk around just trying to feel guilt all the time either, right? There's a toll that can be taken there as well. But to the extent that we can orient towards specific actions, guilt is a more constructive emotion. Okay, so usually I would take time for questions here. I don't have it, but if you have questions, please put them in the chat, and I'd be glad to clarify any of these points at the end. I'm going to pivot us now just to our research. This is a very high level overview of some of our key findings. And I just would refer you to the papers for a lot more richness, I think, in depth. But this is some of the self-talk that we encountered when we asked, in this case, residents and medical students to describe how they felt about themselves or saw themselves in a shame state. This is actually how we knew that they were talking about shame and not something else, because these were all global negative descriptors of the self. So it aligned with what our theory would define as shame. And if you were counseling any one of these people on how to improve, and this is what was deficient or what they saw, this would be very hard to find out what to fix, right? So this is a really good example of how global and kind of diffuse the self-evaluation can be in a negative sense. It also gives you some insight into how harshly our learners are self-evaluating. We looked at what events trigger shame. We call these shame triggers. What were the events that precipitated the shame reaction? And this is a truncated list, but I'm just giving you the abbreviated one. Patient care events were very common. These were some of the most profound, especially among residents, especially if the patient was harmed or died. And we had 2 stories of residents that felt that they killed a patient with an error, and the shame was incredibly profound. We also found shame related to having impaired empathy with a patient, showing emotion in front of a patient, ruminating about all the ways they could have hurt a patient, even though they didn't. So patient care was central in many ways to shame experiences, especially among residents practicing clinically. We found a ton of shame related to learning and assessment. We were really surprised at the time. I'm no longer surprised by this. But the shame related to learning was especially interesting, and it layered into a couple of categories. One category were those events that we would consider to be normal in a learning process that you can't avoid. Being wrong in public, struggling on a new learning task, struggling on a test, being below average. Events that are inevitable in a learning process for which many of our participants were unprepared emotionally and could cause them significant shame. There were also a series of events that occurred during learning that were not normal, should not be inevitable or inherent, like being humiliated, being marginalized on a team, receiving microaggressions or frank racism, being ostracized or harshly interrogated to the point of humiliation. All right, so these things that were happening as part of medical learning that were not surprisingly causing shame, which could be really profound. And then we found a lot of shame related to assessment. This was particularly potent in pre-med and sort of early medical students. And this was typically objective assessment, using numbers that made it very easy to stratify against other people and to sort of draw a conclusion that I did worse than them, therefore I am worse than them, right? And there's something wrong with me. And we have a host of ways that assessment could drive shame, and some key takeaways from that I'll hold off on. And then finally, mistreatment, I've kind of emphasized already, but mistreatment was a really pervasive, unfortunately, but not surprisingly, shame trigger throughout all 3 studies that highlights the incredible emotional impact of this unbelievable behavior that is manifesting in our learning environments. That we, in the course of training doctors, are mistreating them to the point of profound shame and other emotional distress is an incredible moral issue that we have got to address, if not a practical one. We then identified shame promoters, which we called or identified as those factors that either predispose shame, that seem to really increase the risk that it would occur, or that would amplify its intensity, its duration, its potency. So it's kind of like a gas leak that was there before a match strike, or gas being poured onto a small fire. And we have a long list of these, but the few that I'll highlight here just as examples are perfectionism. This was common in our data set. It didn't inherently predispose shame or amplify shame, but it often did. And if you think about the girl in the balloon, the perfectionism is like a storm cloud coming along and just blowing that balloon further away. So even though you may not have positioned yourself differently relative to that balloon, there's now that a greater distance between you and that balloon, which we find provides more opportunities to feel like you're failing to reach an ideal self, and that can predispose more opportunities for shame. That's only really if the person attributes that distance to a flawed self. And we had stories of learners who were perfectionists, but were actually quite resilient in the face of their perfectionism, because each time they failed at it, they oriented towards something they could fix. And it was used in a sort of a positive motivational stance. And so the psychology literature differentiates maladaptive and adaptive perfectionism. And we think shame and guilt may help to modify some of that difference. Tons and tons and tons of comparisons to others across the data sets. This is probably the most pervasive of the shame promoters, and it could take a myriad forms, comparing numbers, comparing performance, often comparing inaccurately. I felt so bad about myself when I heard that chief resident present, and you're an intern. That's not an accurate comparison, how you're performing and how a chief resident is performing. It's really not an accurate comparison how you're performing and your partner is performing, right? You each have different skills and weaknesses and strengths, but those comparisons were very often derived and then help to fuel a shame reaction. Underrepresentation, particularly in our med student and pre-med student studies, was a potent shame promoter for many. Not because it's not important in residence, it just didn't come up in that study for various reasons. The experience of being or perceiving oneself to be outside of the dominant norm in an environment could really fuel shame, especially in the presence of a trigger, such as underperformance or being mistreated. And that could be underrepresentation relative to race or ethnicity or gender identity or sexual orientation. It could be religious beliefs. It could be something like where in the country I'm from or what type of institution I went to for college, a state school or an HBCU. And so these were experiences that really brought it was more of shame because of who I am and not just shame because of what I did. So much so that in a couple participants, just walking into school on the first day of medical school could induce shame when they saw themselves or felt of themselves to be significantly underrepresented in an environment and feeling like that they didn't belong. Finally, one of my favorite of the shame promoters, and the one that crossed all three studies, was essentially a relationship that we identify between how I perform and how I feel about myself. That high degrees of performance over time, not surprisingly or inappropriately, cause high degrees of self-worth, right? But over time, in order to maintain that high degree of self-worth, I have to maintain high performance. And inevitably, at some point in medical training, your performance suffers. It drops. People get sick. You hurt them. You screw something up. You don't know an answer, and self-worth will be hanging in the balance in the midst of that lower performance or perceived performance. Ultimately, what psychology describes this as, we later discovered, is performance-based self-esteem. So that's self-esteem contingent on my perceived level of performance. And we found this to be a very strong contributor to shame, and one that we are continuing to unpack, and I could speak for hours on, frankly. But I'll leave it at that for now. When we looked at the outcomes of shame, just going to put them up here and let you just reflect for a second on them. These were the negative outcomes of shame. Most of the effects that we identify with shame were more negative. The intensity and sort of profundity of which were variable. Some were really profound, some were less so. But it generally was a more destructive emotional experience, but not always. These were the more destructive effects we found. And this is why this matters, right? These are significant. These are significant in terms of what we're trying to do in healthcare and medical training, right? Which is create empathic, connected, resilient, competent future physicians. But it also, there's a deeper underlying kind of moral complexity to this, that in the course of learning, these types of experiences are occurring, creates a real um, kind of exigence. I love that word, like a real need to address this emotion because there's real suffering happening, that may in fact also be affecting our patients. So this is why shame matters, and the good news is that we can do something about it, and we can engage with it. The last part of our research we looked at was what does shame feel like when once it's occurred. And this is where we got into sort of the most hardcore phenomenology, and the most interesting. These are the elements or the parts of the shame experience that we identified at the most sort of fundamental, elemental state. And really, the table is useful right now insofar as it just tells you how incredibly complex this emotional state can be. You're not always experiencing all this when you feel shame, but many of our participants' experiences had multiple of these different elements of a shame reaction. And you can just imagine, like, just the cognitive and emotional load this places on a person, particularly as they try to hide it and sort of suppress it, because shame is something that we tend to want to hide from others. When we looked at the relationships across these elements and structures, to the deeper essences, what we ultimately landed on in this study and identify was that shame tends to be and can be a very destabilizing emotional state. So it takes us off of our emotional axis. As some of our participants described, it felt like emotional vertigo. It felt like I was lacking my anchor, and suddenly I was just sort of adrift out to sea. This quote is great. I love it. It's from um, a clinical year student thinking about the beginning of his clinical year, coming off of a very successful preclinical course, and he really struggled early in his clinical year. And he said, I didn't feel like I was precipitously plummeting emotionally or in how I felt about myself, but I didn't feel safe. It was like the drafts of the success in my first year were just enough to keep me up, right? But I could feel like I could fall at any time. And that precariousness, another person described it as like, it's like you're holding this big glass ball, and it's really thin walled and fragile. And you feel like you have to hold it so tight just to try to keep that sense of self and feel good about yourself as you do this. But if you hold it too tight, it shatters. And if you don't hold it tight enough, it drops. So this, just the precariousness of trying to navigate our identities and our self-esteem and our self-worth as we traverse this continuum is really powerful and complex, and our data oriented us to that complexity. The last thing I'll tell you before I just finish with a couple final takeaways is that we worked with an illustrator to try and visually depict some of these elements and this essence. And we found that in working with shame, it's such a multidimensional construct that words alone, spoken or written, are just not enough to help convey its dimensionality. And so creative modalities have been a really fun way to try to bring this emotion more to life and to make it more accessible. And so she created a 4-panel illustration, and I'm going to just show it to you. It's accessible for free on our website with some discussion questions. I've been using this a lot in workshopping with learners, and in faculty. And it turns out to be an amazing tool because it's abstract enough that there's a lot of different ways to interpret it, but it really conveys some of the emotional dimensions of this experience in a meaningful way. But something's happening here in a presumably clinical learning environment. This person's beginning to have an emotional reaction in response to some event or trigger or treatment. And that reaction is growing in intensity. It's manifesting through some visible displays of distress. And there's some judgment that's potentially occurring or perceived to be occurring from peers surrounding the person, which prompts a desire to run away and hide. It's interesting, some of this really overlaps with my own experience, but this was a very common pattern that we found in our data set. This was definitely not the only way shame could be experienced. What we often found, though, is that after this affective upswell, what we called it, sort of started to die down, as in the case of my error as well, that then freed up the cognitive resources for that deeper self-evaluation. Now that I'm sort of calmer, now I began asking the question, what does this mean for me? This treatment, or this error, or this event. And that can sometimes start as just some kind of casual questions that can then really progress to something more definitive, more energized, more sort of, whereas maybe it was a question, now it's a belief. Whether it was a whisper, now it's a yell. And that can also sort of begin to engulf additional dimensions of the self, not just me as a resident, but also me as a father, me as a caregiver, me as a loved one, me as a worthy person in the world. And so this really depicting in some ways what we identified as shame spirals, or that compounding shame, that especially if it was left unchecked or unengaged upon, could begin to grow and grow, kind of like that forest fire metaphor I used earlier. Critically, as a part of the shame spiral and experience, we identified a process that we call the skewed frame of reference. And this has been talked about in psychology and other ways. Um, and we define that as that within a shame state, or often sometimes leading to or contributing to a spiral, is the challenge or inability to accurately self-assess relative to what objective reality would dictate. So I see myself in this globally flawed, unworthy, blameworthy way, when reality would say, well, you're a early second year resident and you made an understandable mistake in an emergency situation, and you couldn't see anything, and you'd only done one vacuum delivery before. That's what someone talking to me outside of my own head and heart would explain to me. But I was seeing myself totally differently, and I was actually very resistant to that rationality. So the emotion and that skewed frame of reference can really make it hard to engage with this process. And what that practically means is we need to find ways to, as individuals, be able to stop this runaway thinking, and as supporters and teachers and colleagues to support someone in stopping this runaway thinking, and reorient them back to a more rational, goal-directed, sort of action-based set of attributions that ultimately can lead to more engagement and recovery. All right, so how do we do that? I mean, and this is such a short list. It's a shame that it's so short, because I could go on and on about this, but I'm going to give you the highest points to think about. But I want to just first maybe reiterate the importance of caring about shame, right? This is an emotion that can and maybe will happen in the course of what we do, the nature of what we do. It's there. And it can really impair our learning and our well-being, in which ultimately we think can affect patients. So therefore, we have to engage with this. This is not, I don't think this is an option of do we engage with our shame or not. I think we have to, if we want to be the people, and if we want to train the people, and we want to take care of the patients the way that we want and our society needs. And so it has to be engaged with, but it doesn't have to just be about recovery to the point of, baseline. This is an opportunity for growth. We can actually take these experiences and move us to a new place, a new self-concept, and a new level of achievement through a couple of specific steps. So how do we do that? How do we mitigate unnecessary shame and leverage that which remains for growth? The first is we have to stop intentionally shaming people, period, full stop. Unfortunately, it's been used as a very common pedagogy, I think. It's become enculturated. We need more information about how emotionally intentional shaming affects people to really make us understand that this is not an effective nor necessary pedagogy. It's just not. There are better ways to teach someone than to shame them. And I would say if you can't figure out a better way, you really probably shouldn't be teaching in medicine. The second is my other soapbox I'll get on. If we keep only looking at narrow definitions and manifestations of impaired wellness that we can define, and which is everyone's frozen. Are y'all hearing me?
Yeah, we went out for a little bit, Will.
Okay, that's what happens when you get on a soapbox. The internet tries to stop you. We need to care about things that we can't measure so easily and that are stigmatized, and we need to begin talking about them and researching them. If you think a shame reaction might be present, look for some of its manifestations. Think about some of the triggers I've given you. Listen for some of the words and self-talk I've given you. Look for some of the withdrawal and making oneself small and isolation. And then ask about shame. This is one of the most important steps, I think, in getting it out in the open and helping someone recover. And one of the practical ways I've found to do this is to if I sense that someone may be really struggling with a negative self-evaluation, and even if I don't sense it, even if it's just likely, then I'll go beyond this question of how are you feeling, which is a really important question, to how are you feeling about yourself. And what about yourself adds is it takes the person to that self-conscious to self-evaluative level. It goes from basic to self-conscious emotions. And it's so easy to deflect the self-conscious emotions when someone asks how we're feeling or how are we doing. When someone opens the door by saying, how are you feeling about yourself? Like, what do you see right now when you look at yourself? Um, that opens the door for them to share that experience, which can often be really difficult to sort of overcome. So once we've identified that there's shame there, then we name it. That's so powerful to say this. Hey, this is so disorienting and awful and painful, but this is a real thing. It's a very common emotion, and it's called shame. And go watch this Brene Brown video or check out this website, and read more about it. Normalize it. I've been through this before. Just about everyone I know in healthcare has been through this. We just never talk about it, right? Because it's really hard. Tell your own story. Shared experience is one of the most powerful ways to bring someone back into the fold of belonging when they feel ostracized from their own shame, and then help them transition the blame. So I want you to take the blame off of you over here. You've done your check of yourself here, and I want you to move it over here to something we can fix. And then I'm going to partner with you to help you fix that. And you can do that for all sorts of transgressions, right? Even those that need a high degree of accountability. I want you to stop viewing yourself as an unprofessional person and start recognizing that the behavior you've been exhibiting is unprofessional, but we can do something about it, right? And make it better. So we're not letting people off the hook when we shift that blame. We're just trying to orient them to action. And in doing so, we're leveraging the power of guilt. So I would say don't intentionally shame, and I wouldn't necessarily wield guilt all the time, but don't let guilt go to waste. Use that negative tension, the distance there, right, is a motivational launching pad for a person. Focus them towards actions that they can improve, help them practice self-compassion. That's critical for engagement, and then orient them towards growth, no matter how painful it might be. And I think as mentors and supervisors, that's one of our most important things. The final point I'll make is that none of this is going to really work that well. None of the individual intrapersonal level strategies will work if the environment isn't at least somewhat conducive to this engagement. And I would just really encourage you to think about how conducive is your environment to engagement with shame, right? It has to have some fundamental features. It's got to be at least somewhat psychologically safe. People have to be willing to take risks there in your environment. We should mitigate competition. We're all competing against the impossibility of practicing medicine in today's society, against healthcare inequities and societal inequity, against the challenges of getting over this learning curve of learning medicine. Let's compete together against those things and not so much against one another. Where we nurture authentic self-expression. Can you be your authentic self in this environment? Celebrate help seeking, not just facilitate, but celebrate it. And we provide active support, and ultimately we guarantee respectful treatment. When we've done that, we have the opportunity then to leverage that shared experience, to connect with one another, to build community, to facilitate belonging through these challenging experiences that are hard and that destabilize us, but ultimately that humanize us and bring us together. So with that, I'll stop and turn back over to you, Rena.
Will, thank you so, so much. I'm gonna, as you close your slide out and we all get to see you, I want to begin by just really thanking you, acknowledging your work in this area. Just such a tremendous contribution to, I think, the field and to us as educators, and such a call to action. So I want to really acknowledge your work and thank you for sharing your personal story and making it such a wonderful learning space for all of us. And I'm going to ask if you have, we'll take one question in the interest of time. I know we could spend hours and hours with Will, and hopefully we'll have him back in person at some point soon. But if there's one question, raise your hand for me if you don't mind in the Zoom room, and I can see you. And Will, I hope you're seeing the love and congratulatory comments coming to you in the chat. I think everybody is just really, thrilled to hear and learn from you. So if there's no questions, I'm just going to keep on praising Will, so which is really fun for me.
I see one from Lena. Yeah, Lena mentioned in here, any thoughts on literature or literature on how to navigate cultural differences. That's a really important point. And the literature on shame would suggest or say that there are some cross-cultural differences. There's a lot of universal in so far as not that one person experiences shame the same as someone else, but there are some universal features of shame that cross cultures. But there are definitely some cultural contributors to different experiences. One of the places you can find that is in more individualist cultures like our own versus more collectivist cultures, which tend to be more sort of Eastern cultures. Um, what we've realized and acknowledged is that we are collecting and producing information about a more westernized perspective of shame. And so we've begun working with developing a consortium that's in its infancy, and as part of this, the Shame Space, the website I put in, where we're beginning to work with Duke NUS, which is our campus in Singapore, and then Exeter University to create more cross-cultural representations and understandings. And we're starting with a graphic medicine project where we actually have a Singaporean medical student who submitted a story, and we have a Singaporean artist who's creating a comic that brings some of those cultural perspectives into play. We like to build on that significantly with research, engagement, collaboration. And that's where the understanding of those cross-cultural differences will come from. Right now, we just need to be aware that they exist and be open to learning about what they may be.
Thank you, Will. Thank you, thank you, thank you. So friends, thanks, Will, for being here. Thank you all for joining us for Medical Education Grand Rounds. We reunite on April 11th to hear from Dr. Cornelius James, who is at the University of Michigan, who will be speaking to us about how to integrate machine learning technologies and concepts into medical curricula. And he's done some really wonderful work in this space. And so please join us then. And Will, with gratitude, I hope I see you soon in person, and thank you all for joining us again.
Thanks,
Have a
everybody.
great day, everyone.
Take care. Thank you for having me.